Our next speaker is Pat Kelly, who comes to us from South Dakota to talk about his novel approach to treating thoracoabdominal aortic aneurysms with his graft design.
Good morning. Thank you for allowing me to speak. I gotta just figure out these buttons. Okay, so we'll get going. These are my disclosures. Some of this IP has been licensed by Medtronic. Background. We've already had some talks about open thoracoabdominal aneurysm repair, and I think we kind of use that as our gold standard. But none of us want to use this gold standard. None of us want to put patients through this procedure because of a bi-cavity incision. And most of these people, other than the Marfan's patients that are young, they never come out of this the same. And they're quite often have chronic pain and constant margin. So we're all looking for a new approach. And again, this is just a picture showing that incision. It's pretty impressive. So design requirements, I know some of you guys have heard this before, and I'll beat it to death because I think it's important. And it used to be a structural engineer, so before I start any project, I kind of make a list of things that I want done with that design. Well, I think to take this on endovascular, we want something that's durable, that gives us good fixation and seal. We want something that can handle virtually any anatomy. We want something that provides favorable flow characteristics. We'd like something that provides unimpeded flow while we're doing the procedure so that the patient doesn't wake up paraplegic. We want it to be stageable. We want to be able to deploy any part of this system and walk away. And then we want it to be off the shelf. We want one graft that kind of can treat everybody. Now this is one heck of a design criteria. And can we do it? I don't know. If you look at the current designs, which I think are really kind of based on the same methodology, we got T-branch, which tries to somewhat mimic people's anatomy. It's an integrated flow. It's being used around the world. It's approved, and I think it's a very good design. We've got ZFEM, which maybe is a little bit more challenging, but if you have a favorable anatomy, this is a very good approach. Good patency rates of the branches. But again, when you deploy this and when you start deploying this graft, you kind of have to finish the whole case. And then we have TAMBI, and I apologize, I'm only showing the retrograde. They now have the antegrade for the renals. Again, a good design, very, very similar in that you deploy it, you have to kind of finish the whole case to a large extent. But all those grafts have some limitations with anatomy. So whenever you run into it, either you can't get access to these grafts because they're still investigational, or there's angulation that makes it not applicable. What do we go to? We go to chimneys, and we go to parallel grafts. Why do we go to parallel grafts? Because one, it's off the shelf. We've got the stents, we have the grafts, we bring them together. Two, it can handle virtually any anatomy. So again, it's kind of agnostic to people's anatomy. Some of the challenges I think when we do chimneys, especially if we're doing multi-vessel chimneys, is it requires lots of access. You got to have a wire in each of those vessels, celiac, SMA, right and left renals. And then the dreaded gutters. So we've got our branches that have gutters, and if they go parallel, these gutters can be somewhat manageable. If they go oblique, like to the renals, then all of a sudden you get the hypotenuse of a triangle, and they can become big. And the more branches you have, the more gutters. And I think several people think, well, if you start getting into 4 branches, you got too many gutters, you got too much gutter mass, you're really going to have a really bad endo leak, which with aneurysmal growth. The other thing is with these individual branches, you don't get circumferential seal, that's your gutters, but you also don't get circumferential fixation of those branches. So this is great. We like to think of this as a bailout, but this is the first line of treatment for a lot of physicians because, again, it's off the shelf. They have the products. They know how to do this. How do we bring the best of both worlds? Well, I think it requires a paradigm shift. I think it requires proximal deployment, endo bypass, and delayed distal seal. And what I mean by that is here's an example of an aneurysm. We're going to do proximal deployment because if we do proximal deployment and we deploy or we start separating that aortic flow above those visceral vessels, it allows us to, one, stage this. It allows us to have what I think I'll show as good flow characteristics, and it'll allow us to be able to sequentially do this with unimpeded flow while we're working. So we divide aortic flow above the visceral segment, first with a large thoracic bifurcated graft that then divides that flow into a 4-vessel, what we call our manifold, with mobile limbs. Again, not predicated on anybody's anatomy. At this point, you guys can still see that there's still continuous flow. I could stop, I could walk away, I could bring the patient back a month from now and finish the job. Then we do our endo bypasses, and we don't try to break the rules that we learned in open surgery with inflow, conduit, and outflow. We want gradual sweeping bypasses so that we can really have that flow become laminar and have good flow characteristics. Now, from an arm approach, and you can see that we backed off, if this laser is broken, we can back off on our femoral axis where we delivered these 2 grafts. Now we can back that sheath off. We have continuous flow to our pelvis. But from a single arm approach, we can now go through each one of these limbs, one at a time, and do the celiac, the SMA, the right renal, the left renal. And as we go down the aorta, we're working in an area where there's no other competing grafts or no other competing material, so we've got room to work. And we can do one at a time. You can see that there's still continuous perfusion. Again, at any point I can stop and walk away, and it's been done. Then we do delayed distal seal. Now, with that open other limb, we just extend it south, and it's a standard EVAR. It's at this point that in the operation where I tell anesthesia, okay, now let's draw off 10 cc's of spinal fluid, let's get that mean pressure up. Not until this point do I really get terribly concerned on how anesthesia is managing these people's blood pressure. We don't have to raise up their blood pressure to try to provide perfusion to those visceral segments while we're doing our individual branch vessels, because we have unimpeded flow while we're working. And then, again, it's just a standard. So that's the design concept. So how do you bring an idea like this to reality? Well, first you got to partner with industry. You're not going to do this on your own. So we've licensed our IP to Medtronic, and we call this now the Valiant thoracoab stent graft system. And for case planning, it's a modular system. And when you go to case planning, you want to know what the thoracic aorta is, and you want to know what the thoracic aorta is. That's about all you really need, because after that, it's graft-to-graft interaction. So you've got about 5 different sizes of the thoracic bifur. Your manifold's the same. Your visceral bypass is the same. Your infrarenal bifur is the same. And you use standard iliac limbs. So when it comes to off the shelf, you've got 3 to 4 different thoracic sizes, and after that, it's one size fits everybody. That's interesting. I don't know why they did that. Well, that was an interesting slide there. But we will. This slide here should show the thoracic bifur, which is the Valiant component that divides into a 16 millimeter and a 20 millimeter limb. Our manifold system takes that 20 and divides that into 2 14s and then 2 8s. And again, very mobile limbs, kind of back to that methodology of parallel grafting. And this is the assembled system. We've done early device deployments and prototyping, and we've done some finite element analysis, looking at this in some mathematical modeling. And this has been published in JVS, looking at this with regards to standard fenestration, a T-branch, a TAMBI. Guys, I'm sorry, I don't understand why all of a sudden now some of these slides are not showing up where they did when we did the test. But anyway, I think hopefully. But what we found was that when we look at some of the grafts where those branches come off at certain angles, it creates quite a bit of turbulent flow. Whereas when we bring them off in the parallel manner, we see very laminar flow. And when we did a finite element analysis on parallel grafts, we also found that those had very laminar flow. So by the time the flow gets to the individual visceral vessel, the renal, the celiacs, the flow is laminar again and actually doing quite well, which is probably a much more favorable flow for that native tissue. How are we doing? Can I push the button? Oh, look at there. Now we have pictures. So you can see, and I'm going to hit the button and see if it works. So again, you've got T-branch, you've got the TAMBI, and then you have our design with the very laminar flow, as I think you can appreciate, and then our next generation unitary graft. So clinical results, it all looks good in cartoons and stuff, but what about the results? So this is a distribution of 43 patients that we've treated, and this blue line here represents at the point where we actually introduced our unitary graft for treatment of the type 4 thoracoabdominals. And so that these darker red lines are the unitary patients. And this is a distribution of the type of aneurysms between type 1s, 2s, 3s, and 4s and that we've treated. And again, that line represents when at the point where we could actually offer the unitary graft for the type 4s as well. So looking at our clinical results, looking just at the Manifold system of the first 36 patients, of those 36 patients, male to female distribution of 22 to 14, mean age of 72, with ages ranging from 58 years old to 89 years old. Most of these people have had some previous aortic repair. Of the 36, 28 of those were non-emergent garden variety thoracoabdominal aneurysms, 5 type B dissections where vessels came off both true lumen and false lumen, and then we treated 3 emergent leaking thoracoabdominal aneurysms. Intraoperatively, and you got to keep in mind these numbers go from the inception of this technique through today. You can see that these are not healthy people. Most of a good number of these people had ASA scores of 4. The length of surgery varied from 180 minutes to up to 800 minutes. That was a fun case. I still will never forget that. Fluoro time. The one thing that we found that significantly dropped our fluoro time is going to directional sheaths. And then contrast, you can see down from 23 cc's up to 357. We started using CO2 for some of these cases, which really has reduced our contrast load. And then of the 136 potential grafts that could be treated, we were able to treat 132 of those. In hospital, one in-hospital mortality of those 36, it was a gentleman who had the rupture that he died from an MI. Renal failures, 3 of those 36, 2 of those were the ruptured aneurysms. We've seen no CVAs up to this point. We've seen 3 in-hospital paraplesias. None of those occurred immediately after surgery. They occurred on day 6, day 8, as well as day 28. Average length of stay 9.6 days. And I think what's impressive, of these types of thoracoabdominal aneurysms, 20 of 36 of these people were discharged to home. And here's just kind of some examples of the types that we've treated with their CT angios and then afterwards. But we're covering a lot of aorta. How do we apply this to cover a little less aorta? That's where we've moved now to our unitary graft, which is a still same design concept with proximal deployment, endo bypass, and delayed seal. And it's a modular system, once again, trying to create an off-the-shelf product. You can see here we divide that aortic flow from a standard, we use an endurant at this point in time. We divide it into an infrarenal bypass and then to a visceral segments. And this is just some examples of the size. In our limbs, we ranged from 6 to 8 millimeters, depending on our native vessel sizes. So up to this point, we've treated 7 patients. We're going to do patient number 8 next week. 6 men, 1 female. Age distribution, as you can see. Almost half of these patients have had some previous surgery. One of these patients was emergent. She was having active back pain. And again, it's that proximal deployment, endo bypass. You can see that we still provide unimpeded flow while we're working. This is the length of surgery. The surgery length obviously has gotten quite a bit shorter. Intraoperative time, blood loss, fluoro time all have gone down. Total contrast use has dropped significantly as well. And of the 27 potential limbs that could be endobranch, we're able to endobranch all 27. Okay. And in hospital, post-operatively, we've seen no in-hospital mortalities, no MIs up to this point. Renal failure. This is a very different population than the classic the type 1s, type 2, and type 3 thoracoabdominals. Average length of stay 8.6 days, and these people are going home without having to go to nursing homes. We've seen no aneurysm-related mortalities, no 30-day mortalities up to this point. And whenever anybody gets up and says we see none of this or none of that, it means clearly we haven't done enough of them yet, okay? Because there's no zeros in medicine and there's no 100s in medicine. At this point, we've not seen any paraplegia. What we have seen, we had one patient come back with 3 of 4 of the grafts occluded. We lysed it within less than 20 minutes to get in his arm, lysed his celiac, his SMA. Didn't do any intervention, just lysed it. What we did find is that he came in with a hemoglobin of almost 19. He was on chronic lithium, which is like being on Lasix all the time, I learned. I didn't know that. So the guy was extremely dehydrated. Once we lysed him, hydrated him up, put him on antiplatelet therapy, we've not had problems with that since from him. And again, once the visceral, the endo bypass are done, it's just a delayed distal seal. So in clinical summary, looking at all 43 patients, because I think that's how everybody's presenting, they're including their type 4s with their type 1s and 2s and everybody else. We've seen 1 in-hospital mortality, that was that rupture. We've seen 2 30-day mortalities, both those being the ruptures. One gentleman came back on post-op day 28, and I don't know why he died. His graft looked fine, he just died. We've seen no aneurysm-related mortalities. We've seen 2 aneurysm-related mortalities. That's that 30-day mortality, as we already spoke of. We've seen 1 delayed renal failure. It was a gentleman that had only 1 kidney. He came in with a big MI, got hypotensive, and that renal function failed on that. The graft was still open. We've seen 1 delayed paraplegia at 8 months, so 4 total. Of the patients that are a year out of 78 grafts, 76 of them have remained patent with a patency rate of better than 97%. Of the 158 limbs, we've re-intervened on 3, and none of them for stenosis. 1 of them for distal aneurysm in a celiac, and the 2 that we had to lyse. And we've seen 2 type 3 endoleads. It occurred in the very first 2 patients. It was a slightly different design, which we have changed. So, in summary, by approaching this problem from a non-anatomical standpoint of proximal deployment, endo bypass, and delayed distal seal, minimizing our aortic coverage by introducing the unitary graft, we've been able to perform in situ customized aneurysm repairs, handling virtually any anatomy with, I think, very reasonable